morning, everybody. So lovely to see you on this fine, crisp morning. My name is Denise Kluche. I'm the chair of the Knowledge Mobilization and External Relations Committee. Huge name for our powerful committee that has organized this Applied Research Colloquium. Our first colloquium, kind of a combination of the research showcase that happened in past years and the community forum. We're delighted that you're here today. We expected 70 participants. We have 130 registered, so we're just tremendously excited about that. We hope that you have an exciting and enriching day. We have a lot of exciting presenters for you, and so we just hope for a wonderful day. I have a few, actually, and this is Embrace Aging Month. I wanted to mention that too. So again, very timely that we have this event, and hopefully you're able to participate in many of those things as well. I want to thank the staff who have been working in Herculean kinds of ways in the last few days to pull everything together for this, as well as all of the volunteers, students, faculty, research affiliates, DEHA representatives, and others who have been part of the ART Committee and the Knowledge Mobilization Committee. Thank you very much for your efforts. So you have a lovely little swag bag and a program in your packages. I just want to highlight a few housekeeping things for you before we get started. There's a map on pages 9 and 10 for you. This is one of the main rooms for the events that are going on. The other rooms are just down the hall, the Sinclair, Henderson, and Mackenzie rooms. There are washrooms in the center of that. The posters will take place in the breaks on the upper level. The Harrow room, and there is an elevator for those of you that might need it. Just as you came in the front door there, there's a ramp and an elevator right there if you need that. So, I've covered off the washrooms, all of the important things that way. There's a morning break between 10 and 10:30. Posters, no, covered that. Okay, so the other things I want to mention for you, there are two kinds of evaluation forms in your package. One for the overall event. There's just one overall evaluation form. It's changing on the fly. Thank you, staff, for keeping me straight. Okay, so the other thing I want to let you know about or remind you of is that in the month of April, there are 4 Masterminds lectures that you may want to participate in. The Masterminds lineup is found on page 7 of your program. Another important opportunity for knowledge exchange. And second last thing that I want to do is thank our donors for the program today, who helped us pull this all together and fund it for us. That is the Elder Care Foundation. Thank you very much for your support. The Office of the Vice President Research, Vancouver Island Health Authority, Vice President Academic, Faculty of Graduate Studies, Faculty of Social Sciences, and Faculty of Human and Social Development have all helped to sponsor this event today, and we thank you very much for that support. My last activity is to introduce Holly Tuco, Dr. Holly Tuco, the director of our Center on Aging for the past 3 years. Holly has tremendous background experience as a member of the Psychology Department. She was an Institute of Aging, Canadian Institutes of Health Research Senior Investigator from 2002 to 2007, with her program focused on mental health and aging. She is presently the Victoria Site Investigator for the Canadian Driving Research Initiative for Vehicular Safety in the Elderly, a study following older drivers for 5 years in 7 Canadian cities. And she is a leader for the Psychosocial Factors on Older Driving Decision-Making and Behavior Study. And she is also the psychology theme leader for the nationwide Canadian longitudinal study on aging, a longitudinal study following 50,000 Canadians aged 45 and older for the next 20 years. So we're very excited about the opportunities and possibilities within those research projects as well. Thank you, Holly. Holly is going to introduce our guest speaker. I had 2 minutes to get through these things, so I was kind of rushing through it so we can get on with your day. And so here's Holly to introduce our guest speaker.
So first of all, I'd like to welcome you on behalf of the Center on Aging. This, starting in July of this year, will be our 20th anniversary year. So, and we will join the university, whose 50th anniversary year will start in September. So there will be many events on campus, both for the university and for the Center on Aging during the year coming up. And we look forward to seeing some of you, or all of you, at those events. One of the things we're planning for September is an old-fashioned drive-in theater. So you might want to note that down. There'll be more information posted on our website as we get closer to the date. Also, we will be doing our traditional International Day of the Older Person lecture on October 1st. And in conjunction with that, we'll be once again handing out the Valued Elder Recognition Awards. So those are just a couple of things coming up in the next year. Two little bits before I introduce our speaker. The single evaluation form that we have in your package is a green form. So if you wouldn't mind giving us some feedback about the sessions you go to today. And there's a box, I believe, in each room, or somewhere, to put the evaluation forms in. The other thing I wanted to mention to you is at 3 o'clock, we'll be having a networking reception upstairs in the Harrow room where the posters are. The posters will be judged and the awards for the posters will be given out at the reception. So we are looking at giving out awards for posters that were submitted by graduate students here at the University of Victoria. Okay, now that all that's out of the way, it's my great pleasure to introduce to you Dr. Colette Smart, who is an assistant professor in the Department of Psychology in the Clinical Psychology program. And I can take some of the credit for luring her to UVic. I was the chair of the committee when we were searching for a wonderful neuropsychologist to come to UVic. We found Colette, and we're so happy that she has come here. Her primary interest is in understanding the neural bases for self-regulation in individuals with neurological illness or impairment. Specifically, she's interested in how people engage in moment-to-moment regulation of attention, emotion, and metacognitive awareness within which these processes unfold. In Project SMART, and you may have heard her on the radio or seen her in the paper, Project SMART is the science of meditation and its application to rehabilitation technologies. That's why she calls it SMART, big long title. The team is looking at meditative practices for understanding self-regulation, providing a basis for application of techniques such as mindfulness meditation in the rehabilitation context. And that's some of which she will be telling us about today. So without further ado, please help me welcome Dr. Colette Smart.
Good morning, everyone. It's my great pleasure to be here. And yes, Holly, you can take some credit for bringing me here. And actually, as most of you probably know, UVic is really a centre of excellence for ageing research. And it was a big factor in influencing my decision to actually come in UVic, that I could explore some of the work that I'm going to share with you today. So it's a very important personal milestone for me that I'm here and I can share some of this really exciting work with you. So how did I end up here to share a little personal anecdote? So before I came to faculty, I was actually working in the front lines as a clinical neuropsychologist at a medical centre, as a clinician scientist, doing clinical work and doing research. And I was in a strange position, as new psychologists often are, where you're wearing about 20 different hats. So one of the hats I was wearing, can you hear me? I was working in brain injury rehabilitation, so people with traumatic brain injury, stroke, epilepsy, things like that, and they were going through rehabilitation treatment and making good gains in cognitive and emotional function after their injury. So that was part of where I lived. But then the other part of my job was running a memory disorders clinic where I was working with older adults and in conjunction with two behavioural neurologists, where it was really a diagnostic clinic. And older adults with memory complaints or concerns about dementia. But the difference there was it was purely diagnostic, and then, you know, once we had given the diagnosis, there wasn't much we could do, and that was partially because of the resources of the institution that we worked in. So myself and the neurologist were very frustrated about, you know, why can't we actually offer some kind of intervention to these older adults? And so that was part of what inspired me to start looking at, well, is anyone actually doing any work on rehabilitation of older adults, and what would be the limitations of doing that work? And another part of my journey is also, this is my grandmother here, who I always have to show in presentations. People, when the students taking my 339 class last year on adult development and aging, learned way more about my grandmother than they ever needed to. But she's a big part of the inspiration in the work I do, because she's extremely active, vital, inspirational. You know, she's a constant source of wisdom for me, and I learn a lot about older adults from my interactions with her. So anyway, then I decided, well, I want to really pursue this area of aging research and specifically rehabilitation, and it became clear to me that I was not going to be able to follow that path in the position that I was in. And so that's when I started looking at more of an academic position, and I was blessed with the good fortune to end up here at UVic to pursue this work. So, as many of you are probably aware, this is a really hot time in terms of dementia research, especially Alzheimer's dementia. And the last few years in particular, we've seen huge advances in the biomedical realm in terms of early biomarkers, early detectors of dementia. So it's really an exciting time. But, you know, with all that said, we're still not anywhere close to having any kind of cure for Alzheimer's or other types of dementia. And then also as a psychologist, I often ask myself, well, okay, so we have this biomedical understanding of disease, but how are we actually helping people cope with the disease or try and prevent the disease? And I always go back to this quote from a psychologist I met many years ago, Bob Leahy, who said, pills don't give you skills. So there's a great focus right now on dementia treatment that involves medication, but it doesn't actually empower people that they can actually do anything in their own lives to manage the disease or to prevent further decline. So of course, as a psychologist, that's what's of interest to me. And then another barrier that I was up against was what I refer to as therapeutic nihilism, including the place where I worked before I came here. So, you know, I would say to my boss, who was a pioneer in the field of rehabilitation, I said, well, why don't we start doing some programming for older adults? And then some of the messages came across that, well, older adults are going to decline anyway, so it's kind of a waste of resources, or, you know, what's really the goal of rehabilitation for older adults? It's not the same as younger people, so do we want to waste the resources? So in short, the message was kind of, don't go there. So I like to be contrary, and if someone tells me I can't do something, that's usually my greatest motivation to go ahead and do it. So I want to review some areas of research that are pertinent to why we would even want to try and do rehabilitation programming for older adults, because there are a lot of stereotypes against why we wouldn't want to pursue this research. So I want to try and debunk some of those stereotypes. So neuroplasticity is another area that's very exciting right now in neuroscience, and I think actually this evening you're going to have an opportunity to hear from Brian Christie, who's one of our neuroscientists on campus, and he looks at animal models of aging. And so he's more of an expert in that area than I am, but you'll have an opportunity to hear from him later. But neuroplasticity defined as basically changes that occur in the organization of the brain, especially changes that occur to the location of specific information processing functions as a result of learning and experience. So the idea is that when we do something new, when we learn a new skill, when we engage in a new activity, the brain changes. It changes in structure and it changes in function. And a lot of this work initially came from animal models, so like the work that Brian does, but now is starting to be applied to humans. And in the field of cognitive rehabilitation, this is a really exciting development, because cognitive rehabilitation has also struggled to make its place within mainstream neuropsychology as a valid pursuit. So now that we actually have some basic science evidence that the interventions that we use can actually benefit people. So this was kind of a landmark paper in 2008, Klein and Jones, that talks about principles of what's called experience-dependent plasticity. So neuroplasticity is dependent on the experiences we have to cause those changes. So I want to just touch on these briefly. So the first one, which I'm sure most of you have heard before, use it or lose it. So we know that as we get older, the brain starts to atrophy or decrease in size, which also has an impact on our function. So we have to use the brain and use specific strategies and techniques and be engaged so that we don't lose function and we don't lose structure. Use it and improve it. So we have to keep using the same skills and maintain that over time, or else there's going to be a further decline. The specificity of the training matters, and this is something I'm going to come back to again in the context of the specific work that we are doing. Something that we talk a lot about in intervention research is what's the active ingredient, and some of this language comes from the medical world. But when we look at a treatment for a problem, we think about what's the active ingredient, what is the thing that's actually causing the change for the person. And we know from a neuroplasticity point of view that the training has to specifically match the domain that you're trying to target and improve. Repetition is important, so this is in the rehab world what we call drill and practice. So when you start a new skill, you have to hit hard and hit intensively and hit early after the injury to have the maximal impact. So it can be repetitious, it can be boring, it can be monotonous sometimes for the client, but that's where you're actually going to cause most plastic change. Intensity matters, so this is, again, from the medical lingo, this would be the dose-response relationship. So you can't just do something once a week and then hope that there's going to be change. This is something that has to be done repeatedly, throughout the day over a course of days, at least in the early weeks. And a good example of this is in the aphasia literature, so people who have language disorders after stroke or brain injury. That very intense treatment very early on has the best outcome. Timing matters, but it's, sorry, I missed one of the most important ones, age. So traditionally there's been a view in terms of neuroplasticity, again back to the stereotype that older adults' brains cannot engage in plastic change because the brain is declining in function over time. Well, now we know from people such as Martin Lovedan and Lars Bachman and colleagues of Stuart MacDonald, who some of you may know who's on faculty here, they a lot of work looking at neuroplastic change in older adults and starting to debunk that myth that neuroplasticity is not possible in older age. So the gains may be smaller and it may take more effort, but they are possible. So there is undoubtedly a difference between younger adult brains and older adult brains, but it doesn't mean that it's impossible. The timing matters, but this is poorly understood. Again, this gets to the point of where in a disease process or where in an injury you should intervene, but we tend to think that the earlier the better. And then salience, or the idea of intrinsic motivation. So people have to actually feel motivated and inspired and want to do the techniques for there to actually be benefit. And they've looked at this in terms of animal models, so they have animals like rats or mice learning new skills, and if they're rewarded by food pellets, they do much better and they improve much more than if they are just having to do it on their own. So being able to make the treatment fun and engaging and motivating for people is going to have a much bigger impact. So some of you may have been around last summer. We had Maureen Dennis come visit us, who's a very prominent neuroscientist and actually a child neuropsychologist who's in Toronto. But she is doing a lot of work right now on neuroplasticity. She gave a really fabulous talk because she really emphasized this point. Neuroplasticity is not just for the young. That we can really look at the potential for the older brain to engage in plastic change. We know that experience and opportunity matter, so you have to have a variety of different experiences, an enriched lifestyle, and also the opportunity to engage in new skills. Another area that's important not only for acquired brain injury but also for older adults is something called cognitive reserve. And this is work that Jakob Stern has done a lot in New York at Columbia University. But the way that I would talk to my patients in the clinic about this is the idea of it's your mental bank account. So there's things that put deposits in that bank account, and there's things that make withdrawals. So things that make deposits are having an active lifestyle, engaging in exercise, doing crossword puzzles, having dinner with friends. These are all things that make deposits to your reserve, having a good level of education. And then things that make withdrawals are an unhealthy lifestyle, having vascular risk factors like high blood pressure, high cholesterol. having depression, other things like that. So having a good cognitive reserve is going to boost your ability to really engage in neuroplasticity and benefit from cognitive rehabilitation. And another reason I think why people have been reticent to look at cognitive rehabilitation in older adults is because of the idea that, okay, take Alzheimer's for example. We know that episodic memory or the loss of day-to-day memory is a big problem in people who have Alzheimer's. So then people think, well, memory is a problem, people are not going to be able to learn, they're not going to be able to engage in the techniques. Well, we know this from brain injury that people can learn things in many different ways that don't involve episodic memory. So a good example of that is procedural memory. So something that's a routine that you do every day. You know, a good example of that is riding a bike is not contingent on episodic memory, or knowing how to make a cup of tea. Those kind of skills can be learned even if there's a problem with episodic memory. So you can teach an old dog new tricks. Okay, so now we have some basic science rationale, is my point from this portion of the talk, that we can actually pursue the idea of training in older adults, and they might actually be beneficial. So as someone who worked in rehab, I'm kind of a stickler about the language. So some people use the term cognitive training, some people use cognitive rehabilitation. They use those words interchangeably and they're not necessarily the same thing. So cognitive training is something, again, that has a lot of interest right now, but I think there's more interest in the public domain than there is in terms of research. So this is what my old boss used to call snake oil. You know, when people will say, well, if you just play your Nintendo Wii Game Boy, 5 times a day, you're going to get smarter by 10 IQ points. And people make these really outlandish claims about, basically products. There's basically this big mass market product placement, as I call it. So when people email me and ask me, did you hear about this new cognitive training program? And the first thing I asked is, how much does it cost? Because probably there's a monetary incentive and there's probably not a lot of research behind it. So there has actually been some research that's come out more recently. The interventions tend to be what are referred to as cognitive enrichment. So they're very global, kind of non-specific. So it's hard to know what dose is required to cause a change and also what the mechanism of change is, because there's not really a theory about what's causing change because it's this very diffuse and global intervention. And then those of us who do intervention research in a serious way, the designs are not so well controlled. So a randomized controlled trial is the gold standard, and I'll talk a little bit about that when we get to our project. But that is sort of missing in the research at this point. So again, when I was working with clients in my clinic and they would say, what should I do to try and stay mentally active? And everybody was really interested in Sudoku. Everyone wanted to know, was Sudoku the key to brain health? And basically what I said to them was, do what you enjoy. Thinking back to the salience and motivation piece, we know that people are going to do something if it's intrinsically rewarding. So if you like crosswords, you do crosswords. If you like game shows, do game shows. The only thing I told them not to do was no reality TV because it's like chewing gum for your brain. I know Jersey Shore. Yeah. So now we get to very serious cognitive rehabilitation research, and this was a landmark series of articles that came out in the Journal of International Neuropsychological Society, which is one of our main neuropsych journals. And this series of papers came out at the time that I started really thinking seriously about this work, and so it was really exciting for me. And this is a really tremendous group of people. The Rotman Baycrest Institute in Toronto, which I'm actually going to be going there in a couple of weeks to meet with some of these people, do phenomenal research. Not only are they known internationally for rehabilitation, but they're known internationally for work with older adults. And finally, they have been the first people to catch on. Let's actually bring these two worlds together. So it was a series of articles where they looked at different cognitive rehabilitation programs in healthy elderly, and could they actually create some benefit. So they took 49 community dwelling, functionally independent, healthy older adults, so no dementia yet, mean age of 78, and they did a 12-week intervention program. I think it was 2 hours a week for 6 weeks. And they talked about training the people in general strategic abilities across a broad range of functional domains. And they covered memory, executive functions, and psychosocial skills, but really, for me, the overarching piece was executive functions. For those of you who don't know what executive functions are, I talk about it as the CEO of your brain. So that's usually when you think about the frontal lobes, or the most highly developed part of the brain. So planning, organising, sequencing, time management, all the kind of things a CEO would do. So those are our executive functions. And the executive functions have a big impact on lower cognitive functions like memory and attention and so on. The other thing that's really interesting about executive functions, which I figured out at some point, was they are one of the biggest predictors of independent function of older adults. So being able to pay your bills, being able to drive, being able to keep up with your housework, do shopping. There's such a focus in the older adult literature on memory, but memory is actually not what predicts independent function, it's executive functions. So at some point I was thinking, someone has to actually do some work in this area, because that's what actually predicts what keeps people healthy and living in the community, which, as far as I was concerned as a clinician, that's what matters most. People being able to be in their homes, be happy, doing the things that are important to them, having a sense of independence. So this is largely what they focused on in this study. And this is also probably because Don Stuss is a big executive functions researcher, so that probably had an influence. So they found that the participants had significant benefits not only on neuropsych testing, but also in functional skills, both immediately after the program and then a long-term follow-up. I believe it was 6 months. And as I mentioned, the key ingredient was this strategic or executive control processes. And this caused secondary improvements in other domains. So the ability to which people were able to regulate their cognitive functions, regulate how they engage in tasks, that had a top-down effect on other things like memory. And that ties into my interest in self-regulation, how people regulate themselves in terms of their cognitive and emotional abilities. So this was really exciting work. So putting all of this together, what we've talked about, some of the lessons that are learned for cognitive rehabilitation in older adults. The intensity and the frequency is really important. And also that there has to be attention paid to the emotional and psychosocial elements. So it can't just be cold cognitive. So this is very apparent when you work in brain injury rehabilitation. This is not just a person with a brain injury. This is a person with a brain injury who is maybe depressed because their life has dramatically changed. They can't work now. Family relationships have changed. So that whole piece of it has to be taken into account. You're probably going to see most benefit when people have greater cognitive reserve, which means that they either are not showing a huge amount of decline or they're earlier in the decline process. And then functional relevance, as I mentioned, to me is very exciting to look at executive functions because that's what predicts how people do in their daily life. And to me, that would be the goal of rehab, to actually keep people functional and independent in the community. And another thing, this is something again that we talked about in my undergrad class on older adults, to really capitalize on the strengths of older adults. There's a lot of, as you probably know, negative stereotypes about what older people cannot do or attitudes that they may have. But there's good research to suggest that older adults are compliant with treatment, that they're very engaged, they have intrinsic motivation, and they have emotional stability. And we're going to talk a little bit more about those pieces. Just to speak to the intrinsic motivation piece, so as Holly mentioned, we've had several radio and print ads in the last few weeks for our study. And it's been kind of overwhelming, the amount of response that we've gotten, and my poor grad students have been probably exhausted having to deal with all the phone calls. But we've had something like 140 people contact us just in a, maybe 3-week period. And people that I have spoken to, and I think my students have spoken to, are very excited about this work. So there's definitely a high intrinsic motivation to be involved in this type of study. So that brings me to talking about our study. We're going to be examining the feasibility and impact of mindfulness-based stress reduction as a novel intervention with older adults with subjective cognitive complaints. And we were fortunate enough to be funded by the Alzheimer's Society of Canada, so this is really going to support our work. I want to acknowledge our research team. We have a huge amount of people working with us, both here at UVic and then my collaborator at Brock University, and a lot of undergraduate and graduate students have already been working really hard on this project. So SCI is a subjective cognitive complaints. I've been told in the past I use too many acronyms, so if you forget what things are, just remind me. But the MBSR is the mindfulness training. So when you look at the spectrum of from normal aging to decline, you, at least in the context of Alzheimer's disease, this is what the research shows, that people are in a state of normal aging, and then some people decline to a stage of what is referred to as MCI, or mild cognitive impairment. So they may be showing some changes in memory and maybe some other abilities like executive function, but they still remain independent and active in the community, and their activities of daily living or their ADLs remain intact. So they're still able to cook and drive and go shopping and those kinds of activities. When you cross that threshold of ADL impairment, that's when you reach the level of Alzheimer's dementia. And of course the cognitive decline continues. But that marker of ADL impairment is when people cross that threshold into dementia. So the world of MCI has been very highly researched for a good number of years now, and this is because of people like Ron Peterson at the Mayo Clinic in Rochester, Minnesota. But people wanted to look at folks with MCI and say, okay, if we get these people early, again, maybe we can intervene, maybe we can look at early biomarkers and try and prevent and slow the decline to full Alzheimer's disease. So that's where a lot of the research has been focused for the past few years. But a new area of research that started to emerge maybe in the last 10 years, or maybe even less, is this idea of, there may be a phase even before that called subjective cognitive impairment, or SCI. And some of the people who've done research in this area, Barry Riceberg is definitely one of the main people, he's out of New York. Andy Sakin, who's at Indiana University, and then Laura Rabin, who happens to be a good friend of mine, who also works on Andy Sakin's team. So they identified a group of people who are complaining that they're experiencing changes in their cognitive abilities, but strangely enough, when we test them on our traditional clinical neuropsych tests, they look normal. So for a long time, people dismissed these people and said, well, they're just being too sensitive, there's actually nothing going on, and we shouldn't really worry about it. Well, people like Barry Riceberg said, let's actually follow these people over time and see what happens to them. And sure enough, he followed them over, I think it was a 16-year period, and eventually some of those people started to decline to MCI and then Alzheimer's. Now mind you, not all of them, but some of them did decline. So that suggests that this is an even earlier stage in the spectrum of aging, where we might have a chance to intervene and we might have the best shot to really prevent or slow decline. So again, some of the stereotypes and reasons why people might not have looked more closely at this population. So there's an idea that, well, older adults are just being anxious and depressed in their old age. Maybe they're retired, they have more time to worry about their cognitive function, and so, as providers, we shouldn't be too bothered about that. Well, there's several reasons why that's wrong. So we know from work by people like Laura Carstensen that actually emotional stability and overall positive affect increases over the lifespan. So there's so much focus on what declines as we get older, but as my grad student Bryce pointed out, he said, let's talk about how older adults actually get better over the lifespan. And so emotional intelligence, emotional stability, feeling positive about their life, that actually increases, so that's a strength. So we can't just say older adults are being anxious and depressed, because that doesn't match the literature. Now, if we want to entertain the possibility that depression and anxiety may be playing a role, there is something called pseudo-dementia of depression. This is one of the most common referrals that I would see in my clinical practices. I would get a referral to see an older adult, and the question is, are they experiencing signs of dementia or are they depressed? And the reason for that is because when older adults experience depression, it can actually have a significant impact on their cognitive function. Now, the idea is if the person receives treatment for the depression, then their cognitive function may improve. But actually, other research has shown that even experiencing this condition, experiencing depression in older adulthood, can increase your risk for dementia. So again, it's not a case of, well, it's just depression, we'll treat that and we'll move on. Again, we have to pay attention to these people. Then if we want to take the construct of neuroticism, which is kind of a personality trait that's someone who's anxious, worries a lot, may have a lot of negative thoughts and feelings about their life, there's now work that shows that people who score high in neuroticism have brain atrophy that's actually on a spectrum between normal aging and MCI. So you take someone who looks like they have MCI and you take someone who scores high in neuroticism and they show similar brain changes. So even if it's just mood, it doesn't matter because it's potentially causing the same brain changes. And then other people have said, well, older adults are just being more sensitive to normal aging. We know that sadly after the age of 40, we all start to decline in our cognitive function. So maybe older adults are just very sensitive to those changes and, they're just part of getting older. Well, some of the work that Andy Sagan and Laura Rabin have done, they've managed to find older adults who have no mood and no anxiety symptoms and no neuroticism, but they still have complaints about their cognitive function. And once again, they show brain changes that are on that spectrum with MCI. And then the other issue is, as I mentioned before, typically when we've tested these people, they look normal on our neuropsychological tests. But the question has been raised at some point, well, maybe we're not actually testing the right thing. As I mentioned before, there's this huge focus on memory, and especially episodic memory. But we know even from normal aging and cognitive aging research that, once again, executive functions, so cognitive control, and also prospective memory are some of the things that might actually decline earlier. So prospective memory, again, is very functionally relevant for everybody. So that's been able to remember something that you need to do in the future, like I need to remember I have a doctor's appointment this afternoon, or I need to remember to take my medications at 5 o'clock. So very functionally relevant for people. The literature suggests that those actually might be more sensitive indicators of early decline. And so maybe we've been kind of barking up the wrong tree, so to speak, and looking at the wrong cognitive functions. So the challenge is, what is special about these so-called cognitive complainers versus other healthy older adults? So we need to find tests that are sensitive and specific to discriminate amongst those people. Because I mentioned before, not everyone with cognitive complaints will decline, the same way that not everyone with MCI will decline to Alzheimer's. So what's special about this group who declines? We need to target them. And then we need to come up with some kind of theoretically grounded intervention that's going to address both potential causes of SCI. As I mentioned, the problem with the cognitive training literature is there's not necessarily a theoretical basis for it in terms of they just kind of overload the person with general stimulation, but there's not a specific theory that's based in neuroanatomy or neuropsychology. So as we've talked about, potential causes of subjective cognitive impairment could be mood and anxiety, and it could be early and subtle cognitive dysfunction. So how are we going to find a treatment that's going to address both of those things?
Could you tell us again what SCI is?
The subjective cognitive impairment, so people who have worries that their cognitive function is changing, but they show no problems on tests yet. And so this is our challenge, but the promise is if we can start to wrap our head around this problem, we might actually be able to prevent cognitive decline. We might actually be able to slow people on the progression to MCI or beyond. Did I repeat the same slide? Okay. Yep, so it occurred to me at some point that maybe mindfulness training could be beneficial. Now this may seem like it's coming out of left field, so let me explain why we got to this point. So also to give you a bit of my background, I've been a meditation practitioner for about 14 years now, and I've noticed that it's had a profound impact on my mental function and also my well-being. And when I was in graduate school, that's when the research started to really take hold in terms of mindfulness as a possible intervention in the psychological world. John Kabat-Zinn started this research in the 1970s with people with chronic pain, and since then it's slowly gained traction, but especially in the last decade there's just a huge amount of work being published. It's actually hard to keep up with. So in terms of what mindfulness is, see. Okay, I wanted to do a little demo, but I don't think we're going to have time, so I'm just going to keep going. But I can describe what it is. It's paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. That's often John Kabat-Zinn's quote that's used. So some of the questions I get asked when I give talks on this is, well, isn't this just attention training? And we already have that in cognitive rehabilitation. Well, it does involve regulating your attention, but in a very specific kind of way. So when you do attention training in the context of cognitive rehabilitation, there's a definite goal that you want to make incremental progression in your attention to get to some endpoint. There's no specific goal in mindfulness practice. It's more about the process of just coming back so you can actually experience your lived experience in the present moment. So it's experience for the sake of itself. So it's a very specific type of attention. Other people have said, well, is it just relaxation training? Well, there is a stress reduction or a relaxation component, but again, that's not necessarily the goal. Because if people come in with that goal, then they find they get frustrated with the practice and actually their stress goes up. So it works in a kind of a sneaky way. It's kind of paradoxical because you're being told in the training things like, don't judge your meditation practice, don't judge your experience in daily life. It's about being here exactly in your life at this moment and learning to accept and have kindness and no judgments about what's going on. And so by people actually letting go of those judgments and the needs for things to be different, then they actually experience the relaxation in a very deep way. So this is different from traditional relaxation training. And then something that Marcia Linehan has talked about, she's a researcher at the University of Washington who's worked with people with borderline personality disorder, and she's also used mindfulness in her treatment. She talks about this idea of wise mind, which to me is really about metacognition. So metacognition is traditionally defined as thinking about thinking, so being aware of your mental processes, but in this case, it's being aware and then not necessarily trying to change it or judge it, just noticing and seeing things on a moment-to-moment basis.
What was her name?
Marcia Linehan. She's at the University of Washington. So, you know, mindfulness has some elements of other interventions that we have, but it's very unique in its application. So just to tell you a little bit about the program, so this, John Kabat-Zinn initially put this together in the 1970s, and this has been used now for the last 30-some years. So it's an 8-week, what's called psychoeducation program, so it's not therapy, but people are been given skills to improve their psychological well-being. It's a 2.5-hour weekly session, and they have to do homework. So you have to actually practice the techniques or you don't see any benefit, so back to the neuroplasticity piece. Part of it is actually learning mindfulness practices, so we do sitting mindfulness practice, mindfulness of the breath, we do gentle yoga, we do walking meditation, we learn how to bring mindfulness to daily activities like having a meal, having a conversation. And then there's also sort of a cognitive behavioral element in terms of looking at the kind of attitudes we have towards our state of mind. So it might be getting very frustrated with the fact that I forget things, or getting very agitated about the fact that I couldn't remember something yesterday. So when people get anxious or upset about their cognitive function, that can actually, unfortunately, make it worse. So they have the problem and then they get anxious on top of that, and that kind of exacerbates the whole thing. So the idea would be if somebody has a cognitive slip, let's say, they recognize that and say, okay, well, you know what happened, so let's move on and not be judgmental about it. So they're learning this kind of attitudinal shift towards their mental state. And then there's a full day retreat between weeks 7 and 8 where they come together as a group and we go through in silence the different practices. So there's really good literature now about mindfulness and psychological well-being. So it's been used a lot in medical populations, so people who have chronic and terminal illness. So that's a situation that's potentially not going to resolve, so people have a lot of psychological distress about that. So learning how to be okay with that and actually make meaning in their lives. So it was initially first done with chronic pain. There's a huge group at the University of Alberta that does this work with cancer patients. psoriasis, skin disorders, and then immune function, so any kind of autoimmune conditions. It's also been used in straight mental health populations, so people with generalized stress, depression. Once again, another group in Toronto who does mindfulness cognitive therapy for depression, substance abuse and eating disorders, and that work's done in the University of Washington, a lot of that work. And so the treatment is also very different from our standard clinical psychological treatments in terms of we've adopted a lot of the medical model approach to things and trying to make our science more rigorous, but that has necessarily meant that there's a very heavy focus on symptom reduction. Well, mindfulness is not really about that. It's about accepting where you are and trying to develop kindness and non-judgmentalness. And the symptoms may go down, but that's not really the focus. It's not the idea that everybody should be happy and perfect all the time. You know, we're real people with real lives and all kinds of emotions. So on my journey to developing this project, I wrote a review paper in 2009 that was looking at mindfulness meditation in terms of people who do this in a very serious way. So that was some of the clinical literature that I presented to you. Now, what about people who actually do this for a living, so to speak? So studies such as fMRI, or functional magnetic resonance imaging, and also EEG, which is when you have all those electrodes on your head, have shown fairly robust evidence that circuits that are related to self-directed attention and executive control, those show increased activation when people practice mindfulness in a sustained way. So the very same brain circuits that we're thinking about targeting in this population. Other fMRI studies have shown a greater ability to disengage from self-directed narratives. So that's this idea that you've had a cognitive slip and now you're going to start judging yourself and getting anxious about it. Well, people can disengage from those narratives when they practice mindfulness in an ongoing way. And also change their attitude towards their emotions. So instead of feeling overwhelmed by anxiety, just being able to tell yourself, okay, this is anxiety, I'm experiencing anxiety, this is not going to kill me. So these are some very positive changes that people experience when they do this in a serious way. And then one of the things that was really exciting to me, again from a neuroplasticity point of view, a landmark paper in 2005 by Sarah Lazar's group at Harvard that showed that people who practiced mindfulness meditation in a serious long-term way showed increase in brain volume in areas related to executive control. But the really cool piece was the older adults in the study had less brain shrinkage than the older adults controls who did not meditate. So for me, that was one of the key pieces in actually developing this study. So some people have said, well, can mindfulness is a cognitive skill? Can you really train this to people who already have cognitive impairment? And this is really a brand new area, and this is what I consider to be kind of my niche, using mindfulness or other meditative practices in people who have brain impairment. So a study in 2008 that looked at people with ADHD, children and adults, showed positive changes. This is another study out of the Toronto group where they looked at goal management training, which is an executive function rehabilitation program that uses elements of mindfulness. That was with adults with TBI. And then a study that I was a co-investigator on before I came here, where we looked at adults with chronic mild TBI, and we took the standard mindfulness program and tailored it specifically to that population. So not just doing a one-size-fits-all approach, but making it very specific to that population. So mindfulness as a potential aspect of rehab is definitely a new innovation. There's not much published on it, which is why it's exciting for me. So I know we're almost out of time, so I'm just going to tell you about our current study. And I probably should be careful what I say in case we have any of the participants here in the audience. So I shouldn't reveal too many secrets, but it's a single-blind randomized controlled trial, which single-blind means when the people come into the groups, I have no idea which group membership they're in. Because we have healthy older adults that have cognitive complaints and do not have cognitive complaints. When they come into the intervention group, I do not know which group they belong to, so that's what the single blind is. And it's a randomized control trial, meaning when people are recruited into the study, they're randomly assigned to either mindfulness training or what's called psychoeducation. So just general information about how the brain works, how it changes as we age, and strategies that you can use to improve it. So the first question we want to answer is, what are some of the specific and sensitive indicators that will discriminate healthy older adults with and without cognitive complaints? And then the second question is, can we deliver this intervention and actually have strategic benefits for people who are showing early impairment? So this is a design. So as I mentioned, we've done initial screenings on at least 130 people, and I think we have some other people still on our wait list to be contacted. We're now at phase 2 screening, where we have at least 70 people who are coming in and doing the next phase of testing. Once people meet our criteria, we don't want to have people with MCI or dementia. They have to be in this healthy older adult group. So once we've screened those people out, then they're going to have a really extensive pre-test workup that includes neuropsychological testing, electrophysiology, MRI, computer tests and questionnaires. Then they'll be randomly assigned to one of these 2 groups. Then after the 8-week intervention is over, we're going to test them immediately again on some of the basic neural measures and also questionnaires. We're going to let them go back to the community and try and practice what they've learned. Have them come back after a month for what's called a booster session to kind of re-energize the skills and re-motivate people. And then at 3 months, contact them once again and do a final round of testing to see if there's been any carryover in the skills that they've learned. So, last slide, some of the benefits of using a program like mindfulness. It's time and cost efficient because it's done in a group modality, it's low cost, it's a psychologist or other healthcare professionals delivering the intervention. Multiple domains are targeted at once. As I said, there's the mood piece, but also the cognitive piece. And then the personal involvement of the actual participant. So rather than this top-down, we're just going to give you a pill or a medication and you're a passive recipient, people are actively engaged in the intervention themselves. The limitations are, to be able to actually do this intervention, you need to have a lot of training yourself. So this is not something that any psychologist or mental health professional could take on. You actually have to have your own mindfulness practice and be trained and able to give this information to other people. Like any other psychological treatment, it's only going to be beneficial for certain types of people. I saw this when we did our work with people with brain injury. Some people were naturally intuitively inclined towards this type of treatment. Other people, it did not connect for them, and that's fine. There's no one size fits all. And again, thinking back to the neuroplasticity piece, participants have to keep this practice up if they want to keep up the benefit. So if they do it for 8 weeks and then stop, they're probably not going to have sustained benefits. So it's something that if you feel that it's helpful for you, you're going to want to keep it up over the long term. And right on time, thank you, Arlene.